Good morning, friends. Today our guest speaker is Dr. Zurzek from Poland. He'll be speaking to us from how do I manage newly diagnosed DLBCL in 2024. This webinar is brought to you by Mumbai Hematology Group. It is supported by Roche, Accurent, Lucien, and Nirvin. Managed by Perfect Square. I thank Team Roche, Nirvin, Lucien, and Accurent. I also thank Mr. Yash and Kalpesh and their team from Perfect Square. I'm grateful to Executive Committee of Mumbai Hematology Group. Our chief guest today is Colonel Dr. Ashok Meshram from Kolkata, who will inaugurate our webinar. As guest speaker, as I mentioned, is Dr. Zurzek from Poland. Our discussants are themselves eminent hematologists or medical oncologists from India and neighboring countries. And I also thank all our participants for sparing their Sunday morning if you are from India, or afternoon or evening from other parts of the world. Next weekend, Saturday, evening 7 p.m. IST. In fact, we are going to start a bit early, 6:20 p.m. this time, as we have two speakers, Dr. Kripa Bajaj from India and Dr. Nasima Gangat from US. And we'll be discussing various aspects of myeloproliferative neoplasms. And next Sunday morning, 11:30 a.m., we have Dr. Carbon, who will be speaking to us on Kesselman disease. Our discussants today, and we have a galaxy of them. I really cannot do justice of introducing them properly to you, but I'll quickly go over their names and the cities. Dr. Jendial from Chandigarh, Dr. Akanksha Garg from Ahmedabad, Dr. Amit Khurana, Surat, Dr. Amit Kaur Kalar from Mumbai, Dr. Ankit Rayani from Ahmedabad, Dr. Ankur Ahuja, Pune, Dr. Ashish Dikshit, Bengaluru, Dr. Bharat Parikh, Ahmedabad, Dr. Chirag Shah, Ahmedabad, Dr. Deep Gala, Lucknow, Dr. Dinesh Bhurani, Delhi, Dr. Dinesh Sheth, Mangaluru, Dr. Fahima Hassan, Prayagraj, Dr. Jaswantini, Hyderabad, Dr. Kripa Bajaj, Hyderabad, Dr. Krishna Kumar Ratnam, Madurai, Dr. Kunal Goyal, Mumbai, Dr. Khushbu Jain, Aurangabad, Dr. Lisa Bulsara, Pune, Dr. Malikarjun, Bengaluru, Dr. Manoj Unni, Kochi, Dr. Mona Vijayan from Lucknow, Dr. Monica Chennareddy from Bengaluru, Dr. Mohammad Rifai from Calicut, Dr. Nishita Shetty, Mangaluru, Dr. Nitin Gupta, Delhi, Colonel Dr. P. Suresh, Delhi, Dr. Prashant Bhatt, Mangaluru, Dr. Pritesh Junagade, Nashik, Dr. Rajan Yadav from Ahmedabad, Dr. Rizwan Akhtar, Lucknow, Dr. Saroj Bala, Raipur, Dr. Satish Kumar A, Bengaluru, Dr. Sitharam Andaram from Bengaluru, Dr. Siddesh Kalantri, Nashik, Dr. Sudarshan Pandit, Nashik, Dr. Tejaswini Gudibande from Durgigudu, Dr. Thomas Kucheria from Kochi, Dr. Yashwant Kashyap, Raipur. It's my pleasure to reintroduce our guest speaker who has spoken to us multiple times during these webinars starting from the COVID 2020, and he has been personally with us for our conferences in Mumbai. He's MD, PhD, he's consultant and professor of hematology at Memorial Maria Sklodowska-Curie National Research Institute of Oncology at Krakow, Poland. He's a consultant and professor of hematology at Jagiellon University, Krakow, Poland, where he leads the lymphoma team from 1992. Most of his research activity in the last 15 years is related to development of monoclonals in B-cell lymphomas and also the practical aspects of stem cell transplantation. The Jagiellon University lymphoma he leads has participated in over 70 clinical trials, including phase 1 followed by expansion cohorts. He's a co-author of publications leading to registration of ibrutinib, idelalisib, belinostat, lenalidomide, venetoclax, and rituximab biosimilars. At present, his research is focused on developing future generation BTK inhibitors, anti-PD-1 molecules, DARTs, and BiTEs. He is a member of numerous scientific societies, to just name a few of them: ASH, ASCO, PLRG, EMCLN, ICOS, and consultant for EMA. His research papers have been published in the prestigious journals, including NEJM, Blood, JCO, The Lancet, Lancet Oncology, Annals of Oncology, etc., with cumulative IF of over 650, H-index of 20, and citation more than 3,000. He will be lecturing on how to manage newly diagnosed DLBCL in 2024. And before that, our pleasure to introduce our chief guest of the day, my friend, Dr. Colonel Ashok Meshram from Kolkata. He's MD Medicine. He did his DM Clinical Hematology from prestigious PGI Chandigarh. He's presently Senior Advisor in the Department of Medicine and Clinical Hematology at the Command Hospital, Kolkata. I invite him to inaugurate our webinar and give some words of wisdom, especially for our junior colleagues. Thank you so much. I will just stop sharing and hand over the platform to our Dr. Ashok Meshra.
Very happy good morning from City of Joy, Kolkata. At the outset, I would like to convey my gratitude and thanks to Honorable Professor M.B. Agrawal sir and Mumbai Hematology Group for honor and opportunity. It's honor to be part of this group from long time as a faculty asking questions and then today as a chief guest. Though I don't deserve that chief guest position, but I feel highly privileged and honored to be chief guest for this webinar. I have been part of this group from my hematology days as a senior resident PGI Chandigarh, and when I first meet MB Agrawal sir in one of the conference, and I was very touched by his personal touch, and it was really amazing. And I just want to quote one example that one patient who has got autoimmunity infections, and I did an NGS and which was suggestive of a combined variable immunodeficiency with LRBA gene mutation. I was in doubt, and I mailed sent a mail to MB Agrawal sir at 12 o'clock in the night, and about how to go about the treatment and all that. And next morning I was surprised to see the detailed mail at 4 a.m. by MB sir about how to go about the treatment. And that was really amazing, and such mentors and brilliant and prompt hematologists like him is really role model for me, for all of us actually, and he is connecting all of us. So actually these webinars are very enriching. Particularly I am attending it since March 2020 after COVID pandemic, and I'm fortunate to learn every weekend new topic in hematology from stalwarts of field. And this message is to my junior colleagues for the particularly who are postgraduate who want to take hematology and hematology resident, that these webinars cover all the aspects about the hematology from pathophysiology, lab, newer advancement, all that. And this actually help us to learn about this topic. And it's been great to talk with the international faculty interaction. And special part I love is the question and answer sessions, so you can always clear your doubts. I just want to quote a story where Buddha's disciple asked him about what should be the purpose of life, and expecting that he will tell about the prosperity, moksha, enlightenment, and all the things. But the Buddha simply replied that the purpose of life should to train your mind. So they got confused. They thought that Buddha not heard the him properly. They again asked, and Buddha tell that the purpose of our life should be to train your mind. And why to train your mind? To do good. So such webinars help us to train our mind to do so that we can do better treatment and better care of our patient. So with this, I thank Dr. M.B. Agrawal sir, teacher par excellence and amazing personality and energetic personality for many of us, and looking forward to talk on DLBCL. Thank you very much, sir.
Thank you, Ashok, for those very kind words and sparing your time to inaugurate our webinar this morning.
Thank you, sir.
Now, of course, we move to the main purpose of the day, that is learning something from our guest speaker from Poland about DLBCL. I remember when we were just students in early days, it was just CHOP and RCHOP, and there was a single entity DLBCL. From there, Professor is going to take us, all of us, to 2024 and see what we do in this year. So over to you, Professor.
Dear Professor Agrawal, thank you so much for inviting me. I think that's the third or the fourth time we have the pleasure to meet. And excuse my t-shirt, but I'm just in my mountain cottage early in the morning. Now, I have just come back from Japan, and having this in mind, I got the impression that we have much more in common. I mean, Indians and Europeans, and it's a larger distance from mentally from Japan to India than from India to Europe. One reason: you like discussing the things, and you have the courage to ask questions. Therefore, I suggest that if anyone wants to ask any sort of questions during my talk, please free to do so, as we don't have any fixed agenda, and I'll be very happy to have a discussion instead of a lecture. Now, talking about unmet medical needs in large B-cell lymphoma, one of them is suboptimal responses to R-CHOP chemotherapy. This is the fact that the R-CHOP was one of the greatest achievements, and it was unshaken standard of care for the last 20 years. Now, quite dramatically, we are moving towards the new standard of care, and our endless efforts to change it, to change R-CHOP, eventually became rewarding. That's the old slide from 2021. However, it reflects what we do in the clinical practice outside clinical studies. Let me be quite clear on that. At the moment, we treat the majority of patients in clinical studies, including literally half of the first-line diffuse large B-cell lymphoma patients. But nevertheless, the standards of care is that we need to have a good diagnosis. And then we already know that the diffuse large B-cell lymphoma, being the majority, but not all of the cases, because we have high grades and high-grade lymphoma, as defined by WHO by the fifth version of WHO classification, we tend to treat differently. And we also have some unique lymphomas which deserve additional cautious, and sometimes we have to treat them differently. Nevertheless, once we have the majority of cases with diffuse large B-cell, some minority are of limited stage. And this limited stage, we can quite securely reduce the number of R-CHOP cycles to 4, as elegantly proven in German randomized study. So if we have a patient with age-adjusted IPI 0 without a blood disease, 4 R-CHOP cycles are more than enough. Or perhaps should I say, on one condition, that in early PET-CT assessment after the second cycle, we can prove that we achieved complete regression. Now, in advanced stages, up to now, 6 R-CHOP chemotherapy cycles sound to be optimal. I don't believe in making it 8 instead of 6. I rather believe in a risk-adopted strategy. But going back to this unmet medical need, I like the real-life experience and not clinical studies. And here you see the British Columbia experience from the past 2 decades with over 3,000 patients. And I want to draw 2 conclusions out of this slide. The first one is that the benchmark is relatively high if we are talking about elderly population and a disseminated lymphoma. But the second is the progression-free survival is literally overlapping with overall survival, which leads us to conclusion that the first-line therapy is actually the most important for prognosis and further fates of our patients. So only 60 to 70% have a chance of cure after R-CHOP. Before we go any further, let us concentrate on what do we have in the 5th version of WHO classification. Well, in the first place, it very elegantly defines high-grade lymphomas. So if for the high-grade lymphoma, we need to have a positive MYC rearrangement together with BCL2 or BCL6 rearrangements. If we have just MYC rearrangement without any of the others, it's more likely to be Burkitt lymphoma. We can also have a high-grade lymphoma if we have 11q gain losses. And some of the high-grade lymphomas, which are called non-otherwise specified. Nevertheless, the category of high-grade lymphomas got somehow circumscribed, mostly genetically, and is very elegantly described. Now, there are a few changes, and some of them for better, some of them for worse. Note that we have a new entity of immune deficiency dysregulation associated lymphomas, where we have in one setting the central nervous system lymphoma, but also lymphoma of the testicle. Does this mean that this is something which we like? Well, from my point of view, putting a primary central nervous system lymphomas in two categories, immune deficiency dysregulation and LBCL of immune privileged sites, does not lead us anywhere, as we treat both of the entities in the same way. We do have a better recognition of some rare lymphomas and mediastinal gray zone lymphoma. However, this is just the top of the iceberg, because we have learned that neither the subclassifications nor the cell of origin leads us anywhere. We do know that ABC subtype is of worse prognosis than germinal center-like. However, as we learned, even a better characteristics is a genetic characteristics, however we take it. And the MCD subtype seems to be actually one of the key proofs for it. MCD subtype is just a part of ABC subtype, maybe 10% of them. However, it's appalling. It has an appallingly bad prognosis, and in general, it does respond to BTK inhibitors in a fantastic way. Therefore, the molecular targeted agents might play an important role in a large B-cell lymphoma therapy, although not quite and not yet, because it requires new diagnostic tools which are not yet available in every routine diagnostics. So if we have this WHO classification, that's a list of diseases we all know, with non-otherwise specified being the most common subtype. And as I mentioned, there are certain therapies, certain subtypes where R-CHOP is just not adequate. Just to name plasmablastic lymphoma, which is CD20 negative, just to name the primary large B-cell lymphoma of immunoprivileged sites, which otherwise speak against central nervous system lymphoma, Burkitt, which needs a more aggressive therapy, or lymphomatoid granulomatosis, which perhaps does not need therapy at all. However, we have even more disease entities or lymphoma subtypes where alternative therapies to CHOP should be recommended, as the prognosis is poor and we need to make it more intensive. So, in general, if we have a new diffuse large B-cell lymphoma patients, we have certain clinical and molecular aspects which make the lymphoma either of high or low curability, although most of them are in fact the mixture of clinical data and half-lies or half-truths in a way that we are not using the genetic classification so far. Yes? I thought there was a question, sorry. So as you see, we had a lot of clinical studies in the previous era, and all our miserable attempts were in vain. All those R-CHOP 14, R-CHOEPs, and so on, so on. Even dose-adjusted epoch, if tested in a randomized way, did not prove to be any better in all patients unless we go for the subtypes. Now, it's just, let us remind ourselves how medical clinical studies were even 20 or 15 years ago, where we could just replace one cytostatic by the other. It was so boring and so frustrating. Then, in the last decade, we have the new generation of the studies where we tried to add something. But adding something was, again, in most instances, not adequate. Just let's take a Phoenix study to start with. It was a study done in non-GCB diffuse large B-cell, a great approach. We randomized over 800 patients to R-CHOP with ibrutinib or without. Now, what was the net result? I told you about this MCD subtype, which was doing fantastically if ibrutinib was added. However, ibrutinib, although relatively non-toxic, has a certain toxicity. The older the population, the more pronounced. Therefore, this additional toxicity leads to decreasing the dose intensity of a standard R-CHOP chemo, especially in the elderly. Therefore, if additional ibrutinib could help only patients with MCD subtype, which account for 10% of all diffuse large B-cell lymphomas and maybe 40% and maybe 20% of ABC subtype, then in the youngsters where dose intensity was intact, ibrutinib plus R-CHOP meant a great improvement, statistically significant, although in a subgroup analysis. While in the elderly, where you have the dose intensity of R-CHOP decreased, the net result was worse. So the result for the whole study was no change in the whole group, as we had more elderly individuals than youngsters. Well, all that meant is that FDA did not approve it, and all it meant is that we have some sequelae of those studies for the better chosen population. However, it's not going to change our general idea that unless we have a good way to distinguish MCD subtype, the additional ibrutinib will not score. Therefore, it should not be recommended at present. Now, the second was the robust study, another approach with literally 570 patients on board, where we randomized between R-CHOP with and without lenalidomide. And again, there were no differences. The explanation for this was slightly different, because in a subgroup analysis, we could show that there was a better progression-free survival in those with a higher IPI. However, in the whole subgroup, the difference was not significant. Eventually, there was a remodel study with R-CHOP plus minus bortezomib. And then here, and again, a retrospective subgroup analysis showed that it might be better in a molecular-defined high-grade lymphomas only. So again, another study where we have a no. So the recommendation is that we should not add bortezomib for everyone. Although, as I mentioned, in patients with molecular-proven high-grade lymphomas, it was significantly different. Therefore, as you see, the previous phase 3 studies of the last decade were all negative studies. Changing rituximab to obinutuzumab, adding ibrutinib, adding lenalidomide, or adding bortezomib was simply not pragmatic. Let me just let my dog in, otherwise it keeps on howling. So where is the revolution? Let's talk about a targeted therapy, the first-line diffuse large B-cell lymphoma. And we have a legend in Poland about a dragon. You know, it's not just India where you have dragons. And the dragon in our town misbehaved because it wanted more and more virgins. So eventually the city ran out of virgins and intended to kill the dragon. They sent the knights, but they failed. So then a peasant went to the dragon with a sheep full of sulfur. The dragon ate the sheep. The sulfur from the inside burned the dragon, so the dragon started to drink the water from our Vistula river, and it burst into pieces. So eventually exactly the same thing happens with the targeted chemo. And we have two approved agents, polatuzumab and loncastuximab. And in these agents, that's polatuzumab, it's the approved agent for diffuse large B-cell, and it's the same warhead as in brentuximab vedotin, which is approved for Hodgkin disease and anaplastic large cell. We can certainly say that some of the cellular toxin is released to the bloodstream while the complex is circulating, but it may be 3 to 5%. This is what is responsible for peripheral neuropathy. However, the major amount of most of the complexes of monoclonal antibody and the cellular toxin is actually swollen by the neoplastic cell, and there we got it. So we had a polaric study in diffuse large B-cell lymphoma, and in this polaric study, it's another large randomized multicenter approach with 879 patients on board. We took all previously untreated diffuse large B-cell lymphoma patients with IPI 2 to 5, and the stratification factors were according to IPI score, bulky disease, and geographic region. There was one-to-one randomization between polar RCHP. We didn't use vincristine in this subgroup, it was a placebo, versus a normal R-CHOP. Then there were additional 2 cycles of rituximab. That was a Roche study. They always wanted this additional 2 cycles. At least here they didn't press to make it a chemotherapy. Progression, the primary endpoint was progression-free survival, and there was a certain secondary endpoint analysis. The cohorts were well balanced. Now, what is important here is that if you're looking at histological diagnosis, we could have enough double or triple expressors to say that their scheme works in double or triple hit expressors. However, we did not have enough double or triple hit to make any assumptions on how the protocol works in high-grade lymphomas. What we observed at first in response to therapy was a medical improvement in a complete regression rate. However, it meant an important improvement of a progression-free survival. It led to 27% reduction in the risk of progression and relapse or death. So that was the first study ever which proved in overall population examined the improvement in progression-free survival. If we look at the subgroup analysis, it did relatively better in patients with a high IPI of 3 to 5. Certainly did better in the patients without bulky disease. Also, the differences were larger in ABC subgroup, and they were clearly visible in those with dual expression of BCL2 and c-MYC, not double hit, double expressed. This is again seen here. So there was no difference between the patients with a double expressors and not, between the if we treated them in polar RCHP, which was frustrating. Even with a prolonged analysis, we couldn't detect any overall survival differences. However, if we look at it from a broader perspective and we analyzed the therapies we had after failing, it may be self-explanatory. So you see that the patients with R-CHOP got literally twice as frequently radiotherapy, and also we more frequently used systemic therapies, including stem cell transplants and CAR T cells. What was extremely important is that additional polatuzumab didn't meant additional toxicity. Specifically, replacing vincristine by polatuzumab did not mean more polyneuropathy. We certainly observed some neutropenia, but this is something we can deal with. And we also observed twice as many neutropenic fevers. It is a more intensive regimen. So I would use polar RCHP, especially in the high-risk youngsters. But in here, I would like to give you one more, or discuss with you one more feature. If you remember this dramatic regimen we investigated in Hodgkin disease, where you had this ABVD versus brentuximab with AVD. And we gave 12 doses every 2 weeks of targeted chemo. The incidence and severity of polyneuropathy was extreme compared to what we observe if we give targeted chemo on a 3-weekly basis for 6 doses. Both polar RCHP and brentuximab vedotin CHP and anaplastic lymphomas are having an excellent safety profile. Again, that's analyzed here. And as you see, we didn't observe any grade 4 polyneuropathy, just less than 2% grade 3 polyneuropathy, and literally all of the patients recovered. So in a short summary, POLARIX was the first trial in over 20 years to show a meaningful improvement in benefit-risk profile over R-CHOP. In updated data, we demonstrate a sustained positive benefit consistent with primary analysis, and it is regarded, at least in some countries, the new standard of care. And it is in line that ADCs in the first line of aggressive lymphoma therapy are like tsunami, because regardless the diagnosis, there is a benefit. It took us in ECHELON-1 7 years to prove that there is an overall survival difference. In ECHELON-2, when we had anaplastic lymphoma, a much better cycle was used, and the overall survival difference was clear within 3 years of initial observations. With POLARIX study, we all hope that overall survival will eventually occur. The reason why we do not observe it at the moment is the efficacy of the second-line regimens. Now let me go for other things which we had on EHA and ASCO conferences. And as I mentioned, over half of our patients the first-line diffuse large B-cell lymphoma patients we treat in clinical studies. One interesting was a GOLCA study we presented, and GOLCA is a first-class cell-mort agent. And if you remember the story about Icaros and Aiolos and lenalidomide, and if you were ready to use lenalidomide in ABC diffuse large B-cell lymphoma, look at this comparison. Lenalidomide just works in 20% of the cases, while GOLCA in 100%. Meaning that in 100% it leads an active, or rather closed cerebellum, which binds Icaros and Aiolos. Therefore, theoretically at least, it's much more effective. And during EHA, we just presented 1B study, which is a dose-finding study for the third phase protocol, which is currently ongoing. And as you see, we could demonstrate that there was a potent Icaros degradation, much greater with GOLCA than with lenalidomide. It led to an even greater stimulation of T and NK cells. And we observed quite a reasonable cellular destruction. And it was favorably distributed in the target organs. Therefore, as I mentioned, we have the randomized study, which is currently ongoing, that was the phase 1 protocol designed to find the dose for the randomized study. Again, I don't want to go through the toxicities and subsequent subgroups, just saying that we could eventually find the dose. It was relatively well tolerated. The overall response was quite impressive, as we got over 82% of overall responses, which was consistent with circulated ctDNA analysis. And once we achieved the responses, they looked durable. The 12-month duration of response was 97%. And therefore, in a very short summary, we could prove a manageable toxicity, a durable and frequent complete metabolic regressions, irrespective of the cells of origin, high level of MRD negativity. Therefore, I can fully recommend the ongoing phase 3 study. And we are actually, it's one of the 2 studies we are randomizing most of our patients to. Now, at the end of the day, and the end of my talk, let's go to biospecifics. And as you know, we had this French story of 3 musketeers and D'Artagnan. So we have 3 biospecific monoclonals, 3 of them being approved, 1 of them fighting for approval. But before we go to the first line, I just want to share with you what happened in EHA, where in one of the main sessions, the StarGlow study was presented. The StarGlow is a protocol in relapsing refractory patients, so it should not be the part of today's presentation, if not for results. Look at this, a very small study, literally less than 300 patients, 2-to-1 to randomization versus Glofi with Germox and rituximab with Germox. Germox is one of the regimens we use, and I understand that it's a medical regimen. Specifically, we consider the fact that we allowed the patients, or they allowed, because I didn't participate in this study, for more failing 1 or more prior therapies. What is important, however, in this protocol is that although that both the number of chemotherapy cycles and additional glofitamab were both time limited. So the maximum length of therapy was 12 months. Again, the risk group quite elegantly expressed here. And as you're seeing that 60% of patients were refractory to last therapy. Some of them had bulky disease. Most of them were a non-GCB, including ABC subtype. 8% received prior therapy, CAR T cell therapy. That those that very elegant and important endpoints, because in this study, they went for overall survival endpoint. Therefore, we could clearly say that glofitamab would be the standard of care in combination with chemotherapy in the nearby future. Certainly, if you look at the progression-free survival, it was even more evident. If you look at the response rate, we literally doubled the complete response rate. And there was a 33.2% difference in CR rate between 25 and 58%. It was seen, and was the subgroup analysis led to a conclusion that it worked in all subgroups. Again, a relatively well-tolerated regimen with a cytokine release syndrome being observed just in 2 or 3% of cases. I'm talking about grade 3 or greater. As you see, no ICANS, no tumor flare, some infections, but pretty manageable, and neutropenias. However, without more febrile neutropenias. Therefore, we could say that adding a biospecific to a relapsing refractory setting might be a very interesting option. It's one of the first studies where biospecific is combined with chemotherapy. But how it reflects what we can do in the first line. As I mentioned, we are treating majority of our patients in clinical studies. And if you're looking at what happened, and this is on this light blue here, so we had these studies with BTK inhibitors, with PD-1 inhibitors, with chemo-free regimens. It's all happening. However, with biospecifics, it's a vast amount of studies. Some of them, like the epcoritamab study with R-CHOP, where we randomize R-CHOP and R-CHOP with epcoritamab, are fully recruited and just waiting for the readout. And if we look at the study, the data we have, that the EPCO NHL2 is EPCO plus R plus CHOP. It was a dose-finding study for the randomized study. But if we added epcoritamab to R-CHOP, we had 100% response rate, including 80% of CRs, and this was in a dose-finding study. As I mentioned, the proper phase 3 protocol is fully recruited, and the readout will be in 25 and perhaps 26. However, another question which is important is how much chemotherapy we need, because it reminds me that Glofi or EPCO or other bispecific works for immunity. Now, the stronger the chemo, the more it jeopardizes the immune action. I just want to remind you the study which was presented in ASH last year, where we had EPCO plus R-mini-CHOP in elderly individuals. And as you see, the progression-free survival curve was absolutely fantastic. Therefore, we have the Archer study, which is starting in Europe at the moment, run by Hoven. We will participate in this study as well, where the elderly individuals incapable of getting the full dose R-CHOP will got R-mini-CHOP and will be randomized towards Glofi towards EPCO versus placebo. Now, if we can get to the monotherapies, I just want, it's a relapsing refractory setting, so indeed it should not, sorry, too many studies. EPCO NLH5 is a study exploring polar CHP in the first line with epcoritamab. And again, so that's a situation where we give an even more intensive chemo. As you see, again, 100% response rate, 82% of complete responses, and a duration of response pretty encouraging, while most of these responses were achieved relatively early. As for adverse events, apart from neutropenia, we can skip them. Extremely low grades of cytokine release syndrome, ICANS, or other things which could bother us. But as anticipated, if at all we could see any cytokine release syndrome, it was with the first full dose of epcoritamab, which, as the dosing was classical, happened as the third dose. The good, the complete regression rate was confirmed by ctDNA analysis. So that was epcoritamab, but we also had the run-in phase with glofi in R-CHOP patients, and as you see, a slightly inferior overall response rate and complete response rate then in EPCO R-CHOP. Therefore, there was a coalition study where the Roche decided to give either glofitamab to R-CHOP or polar CHP. So again, the more intensive chemotherapy with slightly better overall response rates. And again, there's a currently recruiting phase 3 protocol where you're randomizing patients between polar CHP with or without glofitamab given from the second cycle. The maximum number of glofitamab of glofi doses is defined by the number of chemotherapy doses, so it's given for 8 months. So eventually, before my sore throat will not allow me to continue, let me summarize the other unmet medical needs we have in large B-cell lymphoma, apart from making the results of the R-CHOP better. We have patients ineligible or failing stem cell transplants. However, I must say that we have less and less patients where we even try the stem cell transplants in the CAR T-cell era. We have patients who are ineligible or just have a limited access to the CAR T cells. And here, the biospecifics may play an important role, and eventually patients refractory to the CAR T cells, where we have to know what we can do for them. So how do I manage patients? Well, I mean, just to summarize it, to make therapy as non-toxic as possible. So in patients with IPI 0 without a large tumor burden, perhaps 4 R-CHOP is quite a good thing. Then still a standard of care remains 6 R-CHOP, or if we have a high risk IPI 3 to 5, although theoretically it's also possible for IPI 2 to 5, 6 polar RCHP. However, at least half of my patients are treated in clinical studies, including biospecifics. There is quite a long discussion. What should be first, biospecifics or CAR T-cell? Now, it looks like CAR T-cells are getting established in relapsing refractory settings, but it may happen after the studies which are already completed, that biospecifics will find their place in the first line therapy, which will be quite interesting. Now, before I finish, I just want to make one more comment. If we look at the antibody drug conjugates, so like polatuzumab vedotin, look that we do not have an therapy which is absolutely without any doubts in a relapsing refractory setting. The polatuzumab in a relapsing refractory setting is approved with bendamustine, which we don't like before the CAR T cells. The Lonca is again the therapy which the CAR T cell doctors don't like, as it targets anti-CD19. And unfortunately, the ADC we developed with Debiopharm, naratuximab, anti-CD37, which had results very similar to loncastuximab, is not yet approved, and the company just changed its mind and would like to develop the drug in AML instead of diffuse large B-cell. Thank you very much that you had patience to listen to my boring and prolonged talk, and I will be much more happy to answer the questions than just preach.
Thank you. Great talk. Enjoyed listening to you. Clarity and the quality of slides and the contents were phenomenal. So we are going to use raise hand sign for asking you questions, but I will set the ball rolling. The first question that I have for you is that today, with the whatever subgroup analysis we have with respect to POLA, irrespective of that the study was not meant for subgroup analysis, do you think that we can pick and choose whom to give POLA and whom to give only R-CHOP?
Well, a difficult question, because if you have POLA RCHP reimbursed by NHS, then you may face legal problems if you don't give it to high-risk patients. I personally give outside clinical studies POLA RCHP to those who do not have a great risk of infection. So otherwise speaking, if I have an elderly and comorbid patient, I would not. I tend to give POLA RCHP more happily to those with IPI 3 or greater, as the difference in IPI 2, although existing, is much smaller. And I'm definitely happy to give POLA RCHP to the double expressors. Now, with the double hit, in fact, I mentioned that I treat only high-risk patients with POLA RCHP. Having said so, very few patients got POLA RCHP in my clinic, as most of high-risk patients are actually treated in clinical studies. One of them ongoing is this POLA RCHP versus the same with Glofi. The other is this Golka study. Both were addressing high-risk patients. So I'm trying to persuade my patients to participate. And if I have a high-risk patient, youngster, I'm clearly telling him that we can give him POLA RCHP within NHS. It is reimbursed. But if he takes part in a clinical study, he can get, half of them will get a glofitamab. I got no refusals. And we already had 11 patients in this study.
Thank you so much. Ashish?
Thank you, sir. It was a fantastic talk, actually. A lot of new information. So the question was related to double-hit lymphomas, as you were discussing. So how would you like to treat double-hit lymphoma now if they are not part of the study? You would like to go with those adjusted epoch or POLA RCHP? Considering there were very few cases with double-hit lymphoma. Double expressor, we have some clarity. Double hit, do you think they're going to go along or no?
We don't have any right to say that POLA RCHP is working better in double-hit lymphomas. Therefore, I'm trying to persuade them to take part in clinical studies. And those where clinical studies are not the option, I go for all dose-adjusted epoch. Although I understand that this is not the ideal regimen, and it's rather time-consuming for the department. They need to spend much longer time as inpatients than polar RCHP. So sometimes I'm talking to the patient saying, well, look, we have this and this. What do you choose? Choose your own.
Just one more question, if I'm permitted. That's more theoretical. The way you have shown the APCOR data with the Jamox. If any of the patient who is actually a transplant candidate also, and we use it as a salvage, as a refractory case, and the patient goes in remission, would you like to choose autologous transplant as a consolidation here, or allogenic transplant here as a consolidation, if they are still a transplant candidate in that scenario?
Thank you. A very good question. But let me put it like this. I do not believe in autologous transplants in diffuse large B-cell lymphomas, literally at all. I understand that they are still recommended in the late relapses, which are chemosensitive, but we have the increased body of evidence that both CAR T cells and B-specifics, they all depend, they're all T-cell engagers, they all depend on the T cells. Therefore, I think that all the therapies which decrease the number of T cells will fasten the T cell exhaustion and may not be beneficial. And I just want to share two data with you. One of them comes from mantle cell lymphoma, and there was a paper by Michael Wang published in JCO last year, where he proved that the results, both T cell expansion and talking about CAR T cell, and their efficacy was much less in all bendamustine treated patients, not just those which received bendamustine in the last 6 months, but those who ever received bendamustine. And in mantle cell lymphoma, it is a problem. As a mantle cell lymphoma, we elegantly proved that bendamustine rituximab with rituximab maintenance is the bloody best first-line therapy for the elderly, allowing for medium progression-free survival of 60 months, which was greater than medium progression-free survival for R-CHOP followed by transplant. And there, it's just like the earthquake. Evidently, Michael has a solution, and his solution is that a chemo-free regimen involving both rituximab, ibrutinib, and venetoclax is an option. It's his Window 2 study demonstrating a fantastic 90+ progression-free survival at 3 years. And we should, for mantle cell lymphoma, just to finish this, we should go for individualist therapy and definitely not offer chemotherapy and a bendamustine-based chemotherapy to those with P53 mutation. However, this was the first. The second thing I wanted to share with you is that in the first biospecific studies we had in a relapsing refractory setting, we defined the group as high risk by saying that the patients were refractory to last chemo and so on and so on. And between the others, we said that 40% of them failed the previous CAR T. And in the first impression, I thought, whoa, that's a high risk group. But then I changed my mind, because we didn't give the biospecifics to the patients actually failing CAR T cells. We gave a biospecifics to the patients who responded to the CAR T cells, but then relapsed, which meant that it's a group which already responded to immunotherapy, predisposed to be treated by another immunotherapy. And if we could have perhaps a future scenario where we can give a CAR T after biospecifics or biospecifics after CAR T, perhaps biospecifics with lenalidomide or with Golca or with something else, then we need these T cells. And I think that the autologous transplant, unless we will have a certainty that it's curative, should not be implemented. And allo is a very interesting idea for the chosen population. I would never say that allo is a bad thing, but it's a risky thing.
Got it. Thank you.
Thank you, Ashish. We take a question from the audience. Today, are you giving CNS prophylaxis to any patient of DLBCL newly diagnosed?
Thank you for this question, because it's unsolved matter and we are having a very few achievements in this point. I can just tell you what I do, which I'm not saying is the right thing to do. I'm doing the LP after the second cycle. Now, don't ask me why after the second. It's a matter of religion, because I think that if we are having some lymphoma cells circulating during the presentation, we might actually introduce lymphoma cell to CNS, but maybe it's not a true phenomenon. Therefore, I do the lumbar puncture during the second cycle of chemotherapy. And I made a flow cytometry analysis. I mean, certainly in high-risk patients. And if I see any CNS involvement, we regard it a very serious threat and we treat it accordingly. If there is no CNS involvement, I don't do any CNS prophylaxis, as none of them prove to be literally efficient. If I'm pushed to NHS prophylaxis, what I like most is this high-dose methotrexate after completing R-CHOP, so that it does not jeopardize the R-CHOP dose effectiveness.
Sure, thank you. Kripa, your questions.
So where do we place
Sorry?
the glofitamab right now, sir? Is it the relapse setting, or is there any role in first line, sir, glofitamab? Because we do have, I mean, rightly you mentioned in double expressor and double hit, there is no right regimen to offer right now. And some data we have seen regarding RCEOP regimens in European basis studies. So what do you suggest, sir?
Well, in the first place, I would say that despite all the clinical studies, I see no bloody difference between any of the biospecifics. So this, whatever the company mentions to you about the unique action or unique construction of the biospecifics, they all look the same. So in general, the biospecifics are approved for the third line. And we the second line and both the second and the first line of therapy are still experimental. Nothing is approved yet. Now, I would say that if biospecifics are approved in the first line, it's not going to happen before 26. That's my best guess. So I would not be able to persuade the NHS to pay for the biospecifics, even to the patient at greatest risk in the first line, unless it's offered in the clinical study.
And also, sir, in the primary refractive DLBCL, which is like chemo unresponsive post 3 lines of treatment. So the success rate of CAR-T, like they say, it's a limited even in the studies like what they quote. And in such cases, CAR-T alone will be sufficient, or like glofitamab plus CAR-T also there is a little bit data is there. So right now one patient is there whom we plan for CAR-T, and she's having extensive marrow metastasis, and she's a very young lady. So what do you suggest for her, sir? Like she's affordable for all options.
Well, I think that both CAR-T and biospecifics are exploring the same mechanism. Therefore, possibly there is no great difference. My beloved study, which is not yet done, would be cytoreducing the tumor burden by biospecifics and then giving the CAR-T, or vice versa, giving CAR-T and then having some kind of biospecific maintenance. However, it's all the future. So I would give one or the other, whatever is available and whatever is reimbursed. Now, I just want to draw a conclusion to one thing in the biospecifics with which I have a greater experience than with CAR-T. Specifically, if you have the epcoritamab protocol where biospecifics are given endlessly until progression or until some kind of adverse event, we lost a couple of patients in a complete regressions due to infections, and specifically COVID. So we can forget about COVID in the general population, but not in patients with the neoplastic disease of immune system during therapy. Therefore, if I have an idiot who was not vaccinated to COVID, I would possibly go for the CAR T, as this is a shorter therapy than for biospecific.
Thank you. So one last question, sir. Sorry to take your time. Sir, in autoimmune disorders patients, for like SLE or something who develop lymphomas, so do we need to treat them differently? Do we need to take any precautions additionally, sir, apart from the infection?
With immunotherapy, both CAR T cells and biospecifics are feasible for elderly population. In a way, we can say that biospecifics are less harsh because they offer the same, but chopped into pieces. However, if you look at the total toxicity of the whole therapy, it may occur that the adverse events of biospecifics will be more pronounced than adverse events of the CAR T cells. However, if you took at the adverse events you face after each of the separate doses of biospecifics, they are more tolerable. The tolerance is better. Therefore, presumably in the elderly, the biospecifics might be the answer.
Thank you, sir. Thank you so much, sir.
Thank you. One more question from the audience. Is there any place of maintenance therapy in DLBCL?
Which therapy, sorry?
Maintenance therapy. Maintenance, like lenalidomide.
We were taught that monoclonal antibodies like rituximab did not do the job. But if we are talking about biospecifics and epcoritamab regimens, how otherwise we can call it by then maintenance therapy? Although I must say that I think that the epcoritamab will not score unless it finds the way of a time-limited therapy. And having a lot of patients treated with epcoritamab, I tend to say that this is a regimen which gives us doctors the right to decide when to stop. Therefore, you have to know what you're doing. In some of the patients you want, in some you do not. But as there are no theoretical reasons why you cannot repeat the therapy, I think this question is majorly unsolved. So retreatment or maintenance or just time limited. Time limited is best in terms of adverse events. Epcoritamab regimen or lengthy is nice if you're looking at efficacy, but not that much difference from Glofi. No, we don't know.
Thank you. Akanksha, your question.
And by the way, I sometimes, as far as the CNS lymphomas are concerned, again, I have no papers for it, but lenalidomide is such a cheap drug at the moment. So I tend, if I have a high-risk patient, the one without any neoplastic cells in the cerebral spinal fluid, I sometimes give them a year of lenalidomide after ending of therapy.
Thank you. Yes. Yes, Akanksha.
Yeah. Thank you, sir. Thank you so much, sir, for the lucid talk. So my question is pertaining to the elderly population, especially in patients who present with the high-grade lymphoma, B-cell lymphoma with the concurrent CNS involvement. So in such a scenario, is there any role of polatuzumab-based chemoimmunotherapy?
Which line we're talking about?
So frontline treatment naive, high-grade B-cell lymphoma with a concurrent CNS involvement. An elderly patient having a performance status of above 2.
Very difficult question.
I've had a similar patient in practice, that's why.
What I would do, I would try to find a clinical study with biospecifics that's That would be my first choice. If I couldn't do this, I would still, polar RCHP is a nice regimen, and nobody can make us doctors to give the full doses. So sometimes, like in the relapsing refractory setting, polatuzumab is approved in Polar BR regimen, but if I have to give this as a salvage before the CAR T cells, I tend to give Polar BR with bendamustine dose reduced to 0. So there are different ways of speaking with insurance companies, but I would still, if I had no other choice, I would give Polar RCHP, but I would not be too keen on pushing the doses of a classical chemotherapy, having in mind that we already give the targeted chemo as well.
And how would we cover the CNS part of it? I mean, are we giving high-dose methotrexate in such a case?
No, you mean prophylaxis or therapy?
No, this patient, this is a real case. So he was an elderly gentleman. He was 67 years old. He had a high-grade B-cell lymphoma with BCL2, BCL6, and CMYC were positive. And along with that, the patient had a concurrent CNS involvement. So there was
Oh, sorry. I didn't.
Yes.
I missed this part. If you are saying that we had a CNS involvement,
Yes.
then all I said is false. We are just treating CNS, and
Yes.
by saying so, I tend to start from high-dose cytarabine, as I think that they tolerate it better than methotrexate. But we use both, or sometimes we even try for the metrics. It's just we look at not at the age, but at the biological age of the patient. And if we think that the patient may survive 4 cycles of intensive chemo, we offer him intensive chemo. If we think that he will not survive it, then perhaps we are doing radiotherapy with a standard chemotherapy for the peripheral involvement. Okay.
So it's a systemic involvement plus
if you have a CNS, you treat in the first place the worst thing, and CNS is the worst thing which might.
Sure. Thank you so much.
Bad results, unfortunately.
Can I ask a related question or a rather comment? Would you give alternate cycles of CNS therapy and the R-CHOP-based therapy? Alternate cycles?
No. Because I would say that you can either do one or the other thing good. So if I have a CNS lymphoma with peripheral involvement, or just peripheral, I will give a therapy dedicated towards central nervous system. After 2 cycles, I will certainly examine the patient and see whether the peripheral lymphoma regresses as well, which might. And I will certainly do the early PET-CT assessment to see if it does or it does not. But the CNS lymphoma will kill the patients much faster than the peripheral lymphoma. And therefore, I will concentrate on adequate therapy of CNS lymphoma in the first place. And I will not make altering cycles.
What about a protocol like DHAP, which may take care of both?
Do you believe that DHAP is effective for CNS? I understand that if we have to give something which is prolonging life but not curative, yes. But I wouldn't hope for life. What's wrong about trying chemo and giving radio?
Right. Yes.
And then going back to peripheral lymphoma, but we're talking about the dramatic cases which with really medical chances of cure.
Sure. Yes, sir. Satish, your question.
Thank you, sir. So my question is regarding MCD lymphoma. Do you look for those mutations in clinical practice? And if so, how do you manage them, sir?
No. No, not in clinical practice. We look at them in clinical studies. But what I mentioned is that this molecular targeted therapies, they might change our horizon, but only after we have an appropriate diagnostic methods available and routine. In Europe, we don't.
Right, sir.
I heard that the Chinese are making this study with the BTK inhibitors for the MCD subtype. But again, that's just in China. We haven't done that in Europe.
Right, sir. My second question was regarding, again, CNS prophylaxis in DLBCL. So you mentioned you do an LP after 2 cycles. If the LP is CSF is fine, clear, and you said in selected cases you give high-dose methotrexate after the completion of R-CHOP. So what are the selected cases? Do you go by site-specific or all high IPI, high CNS IPI score?
No, absolutely by by CNS IPI. This is the first. And then it's always the patient's decision, because if the patient is in a complete regression after completing the standard first line, we have less to lose. We have more to lose. And therefore, I think that we have to discuss all those potentially dangerous treatment modalities with the patient, just discussing the risks with them. And some of them are very eager to have the intensive therapy. Some of them resign.
Right, sir. I had an elderly patient whom I lost due to encephalopathy after high-dose methotrexate. Is there any age cutoff where you don't give high-dose methotrexate, sir?
I'm not very keen on giving the high-dose methotrexate to elderly individuals. However, giving not a high dose of methotrexate is like giving nothing. So either you give this 3.5 grams per square meter, or is this not effective? We have, I shouldn't say so, but we have the very old joke about 2 priests who decided to go for the hookahs and then confess themselves. And one of them said, "One Holy Mary." Okay, they changed the places. And then the other says, "Well, you have to get a pilgrimage on your knees for 1,000 kilometers." And said, "Well, we had a deal. We were to go for the hookahs and then confess ourselves. And what have you done?" "Well, you know, I have the life hack. When I fuck, I fuck. When I confess, I confess." So with a central nervous system, I think that either you treat it adequately or you don't treat it at all. Half measures do not lead us anywhere. So we may believe in lenalidomide, and this is why I sometimes give lenalidomide as an excuse for myself that we've done something against nothing. But if you decide to treat CNS, you have to do it vigorously in a full swing and not pretend to treat it. So if I have the elderly patients with the CNS involvement, I don't look at him, will he survive 1 cycle? I'm looking at him, will he survive at least 4 cycles? If he is a good candidate, chemo is always better than radiotherapy. But if he's not, tough luck. With CNS prophylaxis, we had those endless studies, hundreds of patients analyzed, and no eventual guidelines. What shall we do? Out of that, I took that making an alternative methotrexate during R-CHOP is not adequate because it may jeopardize the R-CHOP results. With high-dose methotrexate, we don't have a single proof that it's really effective. But it's not us to decide. We can tell, okay, to the patient, okay, you have a high risk of CNS involvement. We can either live with it or do something. Doing something may be potentially dangerous, but then we are talking about 2 cycles at a dose, CNS penetrating dose of 3.5 grams per square meter minimum. Certainly, you may measure the methotrexate levels. You may just supplement you have to, and you have to supplement everything which is to be supplemented. But still, it's a harsh cycle.
So, and what age, at elderly age, when you say what elderly age do you give or mini CHOP?
What age? Well, I have. I remember one of my patients, which was allo transplanted in '82. So it all depends from biological age and comorbidities.
Right. Got your answer. Thank you. Thank you so much.
Right. Another question from audience. This is about primary mediastinal large B-cell lymphoma. So do you modify the protocol of DAR epoch 6 cycles in any situation? Any role of
I don't use it.
You don't?
We have our own protocol for mediastinal B-cell lymphoma, which we love. And it's a local protocol. It's a story behind it, because once we first started to treat mediastinal B-cell lymphoma, we knew that rituximab was making the difference, and we knew that the dose-dense chemo made the difference. And because in Poland we couldn't give rituximab with any other regimen than CHOP, so I started, it was 15 or 16 years ago, to treat mediastinal B-cell lymphomas with R-CHOP14. And R-CHOP14 proved to be a crappy cycle for anything except primary mediastinal. And then we had the excellent results of R-CHOP14, where came the rumor about dose-adjusted EPO. So we changed, because everyone did dose-adjusted EPO. So we've done dose-adjusted EPO. For 2 years, we treated with dose-adjusted EPO. We summarized it, the results being 10 to 15% inferior to R-CHOP14. So we are simply not, we went back and we treat all primary mediastinal B-cell lymphomas with R-CHOP14, with mandatory GCSF, and we have 90% success rates, and we are happy with it.
Wonderful. And your endpoint is PET negativity, and then no radiation, no upfront transplant.
Now, that's a very important thing, and we are doing it all PET-based. Now, if we have a PET CR in an early analysis after the second cycle and an adequate reduction of tumor burden, we don't give radiotherapy. With the others, we have doubts. We used to give it until we had the results from a NIVO. Then once we have, because the relapses of primary mediastinal were dramatic. But now once we have NIVO and CAR T cells, we tend not to give radiotherapy if we have a PET CR after the second cycle. Having said so, please do have in mind that a PET result done in early response protocol, which means 2 weeks after the chemo, may be false negative. So if we have a PET negativity after the second cycle, but then after the end of therapy, we see the further tumor shrinkage, important tumor shrinkage, it means that after the second cycle, it was not a true PET negativity, it was a false negativity.
Right. Mallikarjun, your question.
Good afternoon, sir. It was a wonderful lecture, really, not just detailing the current therapy, but also peeking into the future. I might have a regressive question. Number one, in the current world, do you make distinguish between ABC and GCB in the frontline treatment? And you mentioned that sometimes the outcome is offset by increased toxicity in elderly. So would you add bortezomib or lenalidomide both in induction and in maintenance in ABC group?
The answer is I don't believe in ABC and non-GCB and all that. I think that it's a false classification. Okay, ABC or non-GCB have a worse prognosis, but it doesn't tell us how to treat them. So if you're asking about bortezomib, I give it only to the patients with a molecular proven double hit, because there is a difference there. But again, those patients I try to treat in clinical studies or differently than R-CHOP.
Okay.
So basically, I simply think that there was the cellular of origin are not reflecting the true biology of the cells. I mean, of the neoplasms. It's a substitute of worse prognosis, because we know that ABC had a worse prognosis, but we're not yet certain how to treat them.
Okay.
We certainly know that the more intensive, the better, but it's we can't prove it.
And any role of lenalidomide maintenance?
No. unless we want it for CNS.
Okay. And in advanced diffuse large B-cell lymphoma in frontline treatment, where would you consider using radiation? Would you use it at all in any subgroup of patients, radiation therapy?
Very good question. If we want to cure the patients, we don't usually see the tumor burden, which with the necessity of additional radiotherapy. I would say that 10 years ago, I would use radiotherapy for every residual tumor burden, PET negative. Now, I'm using this only if I have good reasons for, like because we are using PET assessments pretty frequently. We're using PET assessments mandatory after the second cycle, and in case of any doubts, after the fourth cycle as well, and definitely at the end of therapy. So if we see any inconsistencies, like if we see that well, I mean, again, difficult to say, because if you have a really large burden, sometimes we use it. Otherwise, we think that the modern therapy of relapsing refractory setting, like even faking the second line and giving CAR T cell in the third line, as we are not yet having the CAR T cells reimbursed in the second line in Poland, might be a good alternative to radiotherapy.
Thank you. So with regards to this PET assessment, I don't think all of us are very religious of doing it at the end of second cycle like we do in Hodgkin's. So if we were to do it, would we escalate therapy in patients who have suboptimal response? How do we use this PET2 in DLBCL? If you could just.
It really tells me what to do after the first line and whether to do anything else or not, because we are looking for a complete clinical regression. Now, would we escalate therapy? I would always consider it, unless we have a spectacular response. Like if you had a tumor burden of 18, 20 centimeters, and you still have a devil 4, but 8 centimeters, I would carry on, definitely.
Thank you.
We look just at devil, the metabolic response. We also look at morphological response as well, and we collaborate it together. If you have the devil 4 and non-impressive morphological regression, I would change the therapy after the second cycle, or at least try to, intend to. And there is a good reason for it. At least in Poland, because if you give 2 cycles of R-CHOP and then 2 cycles of whatever, but you call it a second line, you can clearly give the patient the CAR T cell in the third line.
Thank you. Thank you so much.
Thank you, Malik. Another question from audience. Do you treat CD30 positive DLBCL differently?
Thank you for this question. The answer is no, but because it's not reimbursed. But I want to draw a conclusion to the very nice study where they proved that brentuximab vedotin is working even in CD30 formerly negative patients. And the story behind it is that the immunohistochemical methods are not good enough to detect a low level of CD30 expression, which is high enough for brentuximab vedotin to work. So I would not recommend it as in a general practice. It's not reimbursed by the NHS, but it's definitely an interesting thing to explore in clinical studies.
Thank you. Dr. Saroj.
And we have polatuzumab, so polatuzumab is approved in the same warhead, so why not?
Thank you, sir, for great talk. Sir, my question is there any role of obinutuzumab in salvage plus inotuzumab in first relapse setting instead of rituximab plus salvage?
Well, I mean,
உங்களை நான் எத்தனையோ வாட்டி சொல்லிட்டேன் இன்னைக்கு படத்துக்கு போலாம் இன்னைக்கு படத்துக்கு போலான்னு நீங்க ஒரு இன்ட்ரெஸ்டா எடுத்துக்கல
Fahima, please.
கல்கியை பத்தி உங்ககிட்ட சொல்லலையா
Fahima, please unmute yourself. Fahima.
She was lively. Now,
So,
talking about obinutuzumab,
yes, sir.
Roche will kill me, but I don't see any difference between obi and rituximab in diffuse large B-cell lymphoma. They even done the trial in the first line where they randomized over 700 patients, and there was no difference. I love obinutuzumab in the follicular lymphomas, but not in diffuse large B-cell.
And
So
sir,
the
double
answer
hit
is no.
lymphoma.
I don't use it.
So, sir, if double hit lymphoma, okay, thank you, sir. So, sir, in double hit lymphoma plus CNS involvement, to consider for upfront auto transplant after getting the CMR, would you suggest or not? Double hit plus CNS involvement at presentation, upfront auto transplant.
Well, that's what we still did before CAR T cells. So the upfront transplant, autologous transplant, to consolidate the high-risk patients, I would say that it was the method, if it is the method, if you do not have the access to the CAR T cell. And let's face it, in Poland, we don't have the access to CAR T cell for everyone. So that's why we still use it sometimes.
Okay,
But
thank you, sir.
if you have the access to the CAR T cell, I will not do it.
Okay.
Because the transplant is jeopardizing the T cell therapies, the later T cell therapies.
Thank you, sir.
Thank you, Dr. Sarosh. Another question from audience. What is the place of bone marrow trephine biopsy today in DLBCL?
Of bone marrow, what?
Trephine biopsies. We do trephine biopsies, bone marrow, today in DLBCL.
Not routinely, but just to explore cytopenias or things like that. With a PET assessment, we can clearly see the massive bone marrow involvement. Truly, who cares about the minimum involvement? The bone marrow is the best, the area where the drugs penetrate best. So if lymphomas shrink, they will shrink in the bone marrow in the first place.
The other question is about prophylaxis antimicrobial agents. Do you give them in the treatment of DLBCL?
In frank chemoimmunotherapy, no. We just do the GCSF prophylaxis, but that's a different matter. However, if you're talking about any biospecifics or any fancy things added to chemotherapy, we always do it. And we do for classical prophylaxis with acyclovir for herpes and trimethoprim for pneumocystis. So it's not an antibiotic prophylaxis as such. And the best prophylaxis I know for every lymphoma is trying to persuade the anti-vaxxer to get vaccinated before the initiating of therapy.
Thank you. Dr. Chirag.
Yes, thank you, sir, for a very wonderful talk and great question answer. So unfortunately, Mallikarjun asked most of the questions that I wanted to ask, but I would just kind of take it a bit extension that non-GCB versus GCB we are doing for so many years, and you have answered that therapeutically it doesn't make any difference. But you also mentioned that there are some patients where you would give lenalidomide in maintenance kind of. So ideally, yes, but then there are many patients where where they are not transplant eligible, CAR T eligible because of cost issues or age. And if they are high IPI, would you add something, maybe frontline, maybe from the first cycle or after a PET2, which is not great looking?
Well, I mean, very good question, which I don't have a good answer to, because if you have the patient which is not eligible because of the CAR T cells are not reimbursed, then we have to go back to then the biospecifics are excluded as well. And then we have to go to the past. In the past, we tried to make it as intensive as possible with even autologous stem cell transplant consolidation, the first line of all the high-risk patients. If they are not eligible for autologous stem cell transplant, then whether the other measurements will be effective, I doubt it. I understand that in the population you're talking, lenalidomide is a cheap drug, is a possibility or a alternative. Therefore, although it's not changing a lot, I would consider it an ABC cases.
How about ibrutinib? That also we have generic. So
bingo, you have ibrutinib generic. I love India. Well, well, in a youngster, why not? It was proven that if you do not have a dose reduction of R-CHOP, ibrutinib is helping. 10% better.
right. So okay, so those are some, and what if we started with R-CHOP and we have these patients where at the end of treatment there is not a true complete remission, there are little residual disease, you are worried, and these are again not eligible for any things because of cost, none of the second line, which is a big majority, where CAR T or other things will not be feasible. At that point, would you add something like this if it is ACB?
Well, we have a kind of saying in Poland that faith dies last. So you should not reduce the patient faith that you're doing something. So if you have no chance for a truly effective therapy of proven value, then if you have a cheap ibrutinib, you can give it to them, but only in ABC case, so that at least you had a dash of possibility that it works. But remind you, ibrutinib was never investigated in monotherapy. We don't know. You could just give vitamin C instead. Shall I tell you something which is truly fancy on EHA? Late-breaking abstract session. And there was, I'm saying that we shouldn't say too much about it because the patients will may have a bad way to use it. But you heard all the rumors about vitamin C. And it occurred that they took, there was a Dutch study in late-breaking abstract session, and they took about 500 individuals with myeloid malignancies and cytopenias, and found out that 3/4 of them had deficiency of vitamin C, and they randomized them towards supplementing vitamin C for 1 year versus no. They were all elderly patients, ineligible for any kind of aggressive approaches. And then they just plotted overall survival curves, and there were significantly different for the patients. They supplemented vitamin C.
Great. So just one last question. There was
and that was an official EHA poster, but mind you, there was they were just supplementing it, not giving huge doses or anything like that.
Small doses, yes. So just in the relapse setting, there was a recent publication or an abstract of the 5 drugs that lenalidomide, ibrutinib, I think venetoclax, and rituximab, and I forgot the 5th one, and that showed excellent 3-year survival. Is that something to consider for those who are again cannot afford CAR T or other, or cannot undergo aggressive treatment?
I can't make comment on this because I don't know the data, but just look in how interesting world that we live. You're saying lenalidomide, ibrutinib as a cheap drugs for those who can't afford anything else. Just imagine what would mean 10 years ago with both drugs not having generics.
Thank you, sir.
Chirag, this is published in NEJM now. There is an editorial on it, chemo-free treatment of DLBCL.
Yeah.
Title of the editorial.
What's the fifth drug I forgot there? Yeah. Anyway, I'll look again. Thank you.
Okay. Audience question for sir. If a relapsed DLBCL is CD20 negative, can you still use rituximab?
I would say no. Why should I?
Right.
But the other good, but I would just be very, very, very keen on checking this patient for CD19. Because remember, we still have tafasitamab, we still have CAR T cells, and if it's just CD20 negativity, I think that the ACD may work in patients with low expression of antigen, but naked monoclonals like rituximab most likely will not.
Thank you. Another question is, how do you treat Burkitt-like DLBCL?
Which
Burkitt's-like DLBCL.
Burkitt's? I didn't quite get it.
Maybe somebody who's got a MYC expression very high, 100%. That's a patient of DLBCL.
But a MYC expression and without cytogenetically calling it Burkitt.
So Burkitt's-like, yes, not Burkitt's, Burkitt's-like. Okay.
I would regard it a high-risk diffuse large B-cell lymphoma. So try to treat it accordingly.
Sure. Another question is, any role of POLA to be combined with RDA epoch?
POLA with dose adjusted.
Adjusted epoch.
No clue.
No clue, yeah, sure. Deep, your question.
Thank you, sir, for this excellent overview. So my question is regarding a patient who has multiple extranodal involvement in a case of non-GCB DLBCL. So how would you go about treating such a case?
The connection was bad. Could you repeat the question, please?
Yeah, a patient of non-GCB DLBCL who has multiple extranodal involvement.
It's again, I understood non-GCB diffuse large B-cell with liver involvement.
Yeah, lung, liver, adrenal and renal involvement, multiple extranodal sites, sir.
Just dramatic case with lymphoma everywhere. Now we'll just treat it according to the scriptures and see what happens after the second cycle in the early PET assessment. I would not start with anything extravagant up front, but see how the patient will react, because I would be worried about the possibility of a too massive tumor destruction with the first cycle. I might even consider the same thing as in the elderly, which would mean a steroid pretreatment before initial chemotherapy.
So how would you treat a patient of non-GCB DLBCL who has a bulky disease? So would you still use polatuzumab or in this patient?
Oh, absolutely, because we're not saying that POLA is not working in GC, it's saying that it's working better in ABC. So the answer is absolutely yes, because if you have a bulky disease with IPI free, it's 3 or more. This patient is in a subgroup of patients where POLA-R-CHP works better.
Thank you, sir.
Thank you, Deep. Another question from audience. Any experience of using ALK inhibitors with CNS penetration when there is an isolated CNS relapse of ALK positive ALCL?
Well, in Europe, at least, we will have to have an ethical committee agreement to do it, or do it in clinical studies. Interesting idea, but could be a very dramatic disease anyway.
Right. The next question is, in the era of CAR T and bispecifics, is the salvage chemotherapy obsolete?
Thank you. That's a very good question. It's all the matter of what you believe in and what you do not. If you have the early relapse, because this is what we are talking about, I will try to find a clinical study with a biospecific for this patient. But still, in early relapse, we should try it. And the way I would do it in Poland outside clinical studies, I will do one R-E-sharp and do the PET scan after this first cycle. And if I see a dramatic regression of the tumor, I would say bingo and proceed. If I do not see a PR defined as 50% regression and so on and so on, I would just say that the patient is refractory to the second line and gave him CAR T in the third.
Right. Other question is, do you use Smart Start protocol for any patient?
I heard about it. Sorry, I have no personal experience in it. It looks good.
Sitaram, your question.
Thank you, sir. Thank you, Professor, for excellent talk. Just the question on the primary mediastinal B-cell lymphoma. If I heard it correctly, you said after 2 cycles, there could be false negative on PET sometimes, and then turn out false positive, then could be positive later. How do you explain that?
Well, I mean, if you have the initially good response to therapy, even the PET-CR after 2 cycles, this PET is done in the early assessment mode, because you can be more or less sure that there's a negative PET scan not earlier than 6 weeks after the chemotherapy. Therefore, if you do it 2 weeks after chemotherapy, it still can be false negative. And if you have still a disease there, simply it might develop resistance, and you might have a refractory disease.
Sitaram, what he means is doing early PET may not give you a positive result. And if you would have really done it after 6 weeks, it would have been positive. But you're not waiting for 6 weeks. You're doing it after.
We are waiting for 6 weeks because we want the chemo to be effective.
Want the next cycle to get it.
So you know, with this PET scan done in early response assessment, it's one of the greatest favorable prognostic factors, but it is not 100%. So this is why we always, if we have doubts, we even repeat PET after 4 cycles. If we don't have doubts, we do it. We do it also after the 6 cycles, even if the PET was negative after the 2nd cycle.
Thank you.
But then, if we are happy with the therapy, we just wait for the 6 weeks and do the fully accurate PET scan.
Right. Tejaswini, your question.
Sir, in the present times, is it okay to monitor the patient without PET? In peripheries, we still don't have PET. And as a single agent, which are among the newer agents, which one had the best response? Has it been checked as a single agent? The newer ones which have been tested with R-CHOP as a single agent.
Well, I truly don't know what to say, because from my point of view, the PET scanners are the most cost-efficient way improving therapies. So I would say that a PET scan is a very good diagnostic method. If you don't have it, you're somehow blind, and you have to go to the epoch where we just did the CT scan.
I think here we still have only CT scan. Or we can.
Yeah, but I think that's, yeah, I understand, sorry, but we are a poor country in Poland, but at least they decided that this would be one of the first things to improve, because this is the most cost-efficient way of improving the results.
Thank you. The other question is, do you use polar-based salvage therapy and then do an autologous transplant?
The answer is I don't like autologous transplants.
Right.
We used to limit it. If you have the access to biospecifics and CAR T cells, I think you should forget about them. If you do not, then still we were doing autologous transplants in the late relapses, and in those with partial regressions or high risk as a consolidation of the first line. And this was the medicine we practiced 5 years ago. And I understand that it might be frustrating nowadays, but why not if we don't have the modern therapies available?
Right.
So apart from lenalidomide maintenance, none of them are used as single agent?
We're still talking about lenalidomide maintenance. I'm having a very, I'm not using it frequently. I usually do it only for the patients where I have a great worry about the central nervous system. So I'm not a good patient, not a good person to ask about lenalidomide maintenance.
No, sir. My question was, as a single drug, which among the newer agents, the polatuzumab, glofitamab, which one is better without the R-CHOP?
No, but you don't use polatuzumab in a maintenance.
The just only answer is no. Okay.
Okay.
All right. The next question is, if you have an isolated CNS relapse in a patient of DLBCL, will you treat that patient as primary CNS lymphoma?
Yes. Yes. Matrix.
That is yes. Okay. Dinesh, your question.
Thank you, sir, for the excellent talk.
Sorry,
my question is on elderly, frail DLBCL patients.
1 minute. Huh?
If we can make it the last question, because otherwise my wife will kill me Sunday morning.
No, we will stop, sir. Last question, Dinesh.
So in elderly, frail DLBCL patients, is there any alternative to R-mini-CHOP, like RCOP, which can be given?
A lot of alternatives in clinical studies, no real alternatives in real life.
Thank you.
Thank you.
Extremely grateful to you, sir, for the lecture and a very long QA session.
That was the essence. I told you I would rather have 10 minutes lecture and questions and answers, but as my wife preferred breakfast on Sunday morning, breakfast will mean that if I am to survive, I need to quit.
Sure. Thank you very much, sir. And have a wonderful Sunday ahead. And bye-bye to everybody.
Bye-bye.
Bye, sir. Bye.